I'm going to talk about successes and challenges of UAE and where we are now. One second here. These are my disclosures, although I don't intend to talk about any products unless it comes up in question and answer format. So specifically, what I was asked to address is UAE for symptomatic fibroids and talk about, some of the challenges, the pros and cons of what we face when we talk about UAE and where we are now. So specifically with the publication of the FEMME trial last summer. So I'll give you some updates in that space. And then we're also going to talk about UAE for symptomatic adenomyosis. Now, part of the reason why I love UAE is because we do it for more than just fibroids and adenomyosis, but I'm going to focus specifically on these areas today so that it's not too cumbersome. When I talk about where we are with UFE, specifically for fibroids, I like to kind of break it up into a pro-con list. This is by no means, the entire list of pros and cons, but I think it gives you some idea of the things that are not only good about UAE, but maybe bad about UAE, or at least are misperceptions that we need to kind of discuss. So these are things you already probably know, but on the pro list, it's a global treatment, it's uterine sparing, it's efficacious, and it has a shortened recovery time in comparison to surgical treatments. On the con list, the things that come up, and some are, again, misperceptions, but we need to discuss, are fertility impact, the fact that you can have residual or recurrent disease, fibroid passage, and then pain post-procedure. So the first pro is that it's a global treatment. Now, when you think about other global treatments, really the only other one that comes to mind is a hysterectomy, which of course doesn't maintain the uterus. So this is really the only procedure that's uterine sparing and that also treats all the fibroids at once. Now, myomectomy can address as many fibroids as they want, but typically if a woman has 10 fibroids, myomectomy is by no means going to, they're not going to resect all of those at surgery. And so it's not going to be a global treatment. They may resect the one or two or several that are causing the predominant symptoms, but it's very hard to distinguish that. And so this is one of the areas that I think uterine artery embolization really shines. As you know, fibroids can occur in all different locations, and when we go in with our catheters and treat them via the uterine artery, we can't help but treat all of them at the same time. On the flip side, because we are a global treatment and we're treating the uterine artery, potentially global embolization of the uterus has some kind of impact on fertility, which has been, as you know, long discussed as a controversial area. So where this kind of originated from and how this course has gone in terms of a discussion about fertility impact really started from Mara et al.'s studies. Those were randomized studies. We're going to talk about two of them briefly. This is the first. This was published in 2007. And these were randomized studies looking at UAE and myomectomy. So comparing what I like, Dr. Stewart, Elizabeth Stewart at Mayo Rochester, she's a gynecologist there for you, those of you who don't know her. She phrases it as comparing apples to apples, right? Because they're uterine sparing procedural treatments for fibroids. And so looking at myomectomy and UAE, these are what, this is how it came down. So UAE and myomectomy, looking at pregnancy rate, delivery rate, and abortion, UAE fared worse. So this is in the 2007 study. You can see having a UAE had a relative risk over to the right column. Now, if you look at the perinatal results in this study, there were no significant differences between UAE and myomectomy. So that's good. No differences in the way a woman delivered or preeclampsia or any of those factors that we can talk about around the time of delivery. When we look at Mara et al. Study, so same group, essentially a few different authors, but for the most part, the same group, they did another randomized study, non-randomized, but prospective study in 2012. And this compared UAE with another uterine sparing technique, so laparoscopic uterine artery occlusion. Now, I by no means think that's a method that's heavily used, but nonetheless, it gave us some prospective data. And so when you look at this same group and their pregnancy, delivery, and abortion rates, UAE fared much better in this study and was actually very similar to the laparoscopic uterine artery occlusion data. So putting those side by side from Mara et al. Studies, you kind of wonder, why are they so different? Why is the pregnancy rate so different? Why is the delivery rate so different and the abortion rate so different in these studies? And why did UAE fare so much better in the more recent one? So, part of that is probably, of course, difference in study populations, but and the fact that the second one wasn't randomized. But part of it is just that these are incredibly hard trials, one, to enroll for. These are women who may have other impacts on their fertility for other reasons, particularly their age. Most women who seek a fibroid embolization, the median age of these studies is usually women in their 40s. So all those things, lead to variability and probably a worsening rates than our reality if we're looking at a younger patient population. So that leads me to the FEMME results. So this was the long-awaited trial that compared myomectomy and UAE, the first one that's come out in many, many years, and is a prospective randomized trial published in the New England Journal of Medicine. So really big for those of us interested in the women's health space. This was published in July 2020, current with Fibroid Awareness Month. And so the conclusion from this trial was that myomectomy had a better quality of life because that was the primary outcome. We'll talk about that. But throughout this talk, I'm just going to kind of weave in the data from the FEMME trial and how it shakes out in all these different areas that we talk about from a pro-con perspective. So the FEMME trial, in regard to pregnancy outcomes, you can see here the rates were all pretty dismal, both in the UAE and myomectomy group, but the interesting part was they were not significantly different. So if you look at UAE, 8% of women reported pregnancy, 4% in myomectomy, not significantly different. If you look at it in a slightly different way, in women who were actually desiring pregnancy at the time of randomization, about 17% in UAE group, achieved pregnancy versus 10% in the myomectomy group. Now, remember, again, the median age of these patients is in their 40s. So, they're likely to have other factors that contribute to their inability to get pregnant other than getting a treatment of their uterus. So let's turn and talk about one of the other pros on our list, and that is that UAE is uterine sparing. So this is an article that was published in Menopause by Elizabeth Stewart, the woman I described before, and her group at Mayo. And so this was a look at about 2,000 women who had ovarian sparing hysterectomy and matched these to age comparisons in their same community in Minnesota. And so when you follow these women for about 20 years, which is a really great length of time to kind of look at this cohort, what was noticed was that there were signal and significant differences in their cardiovascular and metabolic disease profile. So these highlighted here. So women who had an ovarian sparing hysterectomy, so their ovaries were left behind, compared to women who didn't have a hysterectomy. These women who had the hysterectomy experienced higher levels of hyperlipidemia, hypertension, obesity, cardiac arrhythmias, and coronary artery disease. So this is why I put UAE in the pro category in terms of being uterine sparing, because maybe it is important to not only reserve the ovaries, but actually to reserve the uterus. Now, on the flip side of that, when you preserve the uterus, any uterine preserving treatment, whether it be myomectomy or UAE, you know that you can get residual and recurrent disease with regard to fibroids. So one of the other major studies, we'll talk about basically 3 here today, other than those fertility trials I mentioned. FEMME, we've already talked about, that long-awaited trial that we just got results of. We'll also talk about REST, that's this trial, and then EMME. And those are kind of the big ones that have been in the UAE space and compared UAE to other surgical treatments. So here we're going to just touch on REST with regard to fibroid disease and whether, and looking at not only residual disease, but recurrent disease. So this was a trial that was a prospective randomized trial, and it compared UAE to other surgical treatments, meaning both myomectomy and hysterectomy. And if you look at the 5-year reintervention rate, UAE was at about 32% and surgery was 4%. Now, part of this is the fact that if you're including all surgery, so you're including hysterectomies in this, now those patients have already had a hysterectomy. So clearly the reintervention rate is going to be lower because they're not going to develop as much recurrent disease. They can't, they no longer have a uterus. So this is certainly biased in some ways, but we know that with UAE, if we leave uninfarcted fibroid tissue around, that has a propensity to grow back. So here, I like this example. This was, these are images courtesy of one of my mentors, Jim Spies. And if you look on the far left, this is the preoperative or pre-procedure MRI images post-contrast, you see this large fibroid. You see post at 3 months, the second image, most of the fibroid is devascularized, but there's a small portion that still remains vascularized at the inferior margin. And you can see how it grows back over time. So year 1, year 2, year 3. And ultimately, this patient had symptom recurrence and had a hysterectomy at 3 years. And we know this is a possibility with fibroid disease. We also know that if a woman has a UAE at 40 years old and she has more than 10 years left before she goes into menopause, even if we do a great job and get 100% infarction of her fibroids, there's a chance that she was a fibroid grower before, so she can grow back new fibroids that have nothing to do with residual disease. So, and that's true for myomectomy patients as well. So anybody who has a uterine sparing treatment for fibroids has the possibility of getting both recurrent and residual disease. Now, if you look at the FEMME trial and look at reinterventions, again, UAE fared worse than myomectomy. So 16% of patients had reintervention, and this is in a 2-year period of follow-up, whereas 7% in the myomectomy group, and this was significantly different. One of our other I think pros in the UAE space is that it's very efficacious, especially for an endovascular treatment of any sort. I would say it's one of the more efficacious procedures we actually do in IR. And so you look at these standards of practice published by the SIR, and these are sort of the expectations we have for UAE in regard to fibroids. So you can see we get about a 50 to 60% reduction in fibroid size, a little bit less, but somewhat similar in uterine size. Reduction of bulk symptoms is right around 90%. What most women present with, which is abnormal uterine bleeding, we get greater than 90% efficacy. And then successful elimination of symptoms overall, 75%, and patient satisfaction, 80 to 90%. So really, from an efficacy standpoint, UAE fares very well. What do we expect? So just wanted to throw in some images so you don't get too bored with data. So pre-UAE on the left of your screen with contrast, you see these large enhancing fibroids. Post-UAE, of course, this is only about 3 months later. So we're going to get continued volume reduction, but here you already see volume reduction of the uterus, volume reduction of the fibroids, and of course, lack of enhancement of the fibroids. What about in FEMME? So in the FEMME trial, they looked at quality of life, as I mentioned before, and I've highlighted a couple of things in blue for you here. So if you look at the beginning of the graph, at the baseline, I have that oval there because you can see there were baseline differences in the quality of life scores. So myomectomy actually started the myomectomy patients, despite this being a randomized trial, just by statistical chance, they actually started with a significantly lower quality of life score at baseline. And at the end of the trial, at the 2-year mark, you can see that the confidence intervals overlap between myomectomy and UAE. But in addition, what they actually looked at was the difference. So the difference from baseline to the end of 2 years, and then compared the myomectomy and UAE group. So you can imagine when that's your primary endpoint, which is actually the difference in scores, and you're starting at a lower level of quality of life, that difference is potentially going to be greater, and there's a bias there. What they found was there was an 8-point difference in the myomectomy and UAE groups, and that 8-point difference was statistically significant. Now, if you look at just the absolute score, so that's this table over on the right, and I've highlighted the bottom row for you, the mean quality of life score for UAE was 80, and the mean for myomectomy was 84.6. This is on a 100-point scale. And with a higher number being better. Again, this was found to be statistically significant, but I would argue that on a 100-point scale, a 4-point difference between UAE and myomectomy probably makes very little clinical difference. And that's why the conclusion of this trial, although initially received by IRs as a negative conclusion, when you really dissect through the data, maybe there's not so much negativity here. And in fact, maybe it's really just showing us what we already know, which is that fibroids can be treated in a uterine preserving method by either UAE or myomectomy and achieve a great quality of life afterwards. Okay, one of our other cons is that, maybe we do such a good job in devascularizing the fibroids, as we talked about in terms of efficacy, but on the flip side, that devascularization leads to fibroid passage. So this is just a look at pooling of data on complication rates. And one of the complications that I find to be most significant is, of course, fibroid passage. And so we see here that with pooled data, we have about a 5%, slightly less risk of causing fibroid passage. What does that look like? So here's some images of pre-UAE. You can see this very large submucosal fibroids, and these are the ones we really have to worry about. I showed you that initial image when we were talking about global treatment of the uterus, where we looked at the locations of fibroids. And for me, location of fibroids and how we talk about them is the whole lecture in itself. But I'll just say that if you have a large submucosal fibroid or one that has intercavitary extension, those are the ones that should sound an alarm for you, and you have to really think about whether UAE is the best treatment for them. And also, if you decide to move forward with UAE, having backup plan in place and that setting of expectations with the patient. So this is a large submucosal fibroid, and you can see on the right-sided image, mostly enhancing. Now, this is when the patient presented with symptoms post-UAE. You can actually see that this fibroid is totally devascularized in the right-sided image. But what you can also see is that it's trying to pass through the cervical os, and there's cervical os dilatation. So the problem with this is that not only does the patient have a miserable quality of life if they're constantly shedding this fibroid, but also that the dilation of the cervical os can lead to endometritis and overall infection of the uterus. So you have to be really careful about how to handle these. That's not to say, I should mention that you can't treat a submucosal fibroid. I have some strategies of how I work around some of these issues with the gynecologists that I trust and work with closely, but you really have to think about it. And that's just something that needs to be put forth in your clinic consultation. One of the other pros for uterine artery embolization is certainly the recovery time. So patients, in comparison to surgical treatments, definitely have a shorter hospital stay and shorter recovery time. This is one of those other trials I mentioned before. So the FEMME trial, which was another randomized trial within the uterine fibroid space, that looked at UAE in comparison to hysterectomy specifically, so not myomectomy. And what was shown, this is a little bit hard to read, but if you look in the parentheses of the first highlighted row, those are the mean duration of hospital stays. So if you look in the UAE group, it was 1.7 days. And of course, this is older data, so I would argue that it's even less for both UAE and hysterectomy at this point, but 1.7 hospital days versus 5.1 hospital days. And then if you look at absence from work, again, I think this is not realistic right now, but 21 days for UAE, 46 days for hysterectomy. So how about in the FEMME trial? So this is our more recent data, so let's look at that. So FEMME length of stay, UAE group was 2 days versus myomectomy group was 4 days. And I would also say that when you're talking about recovery time, one of the things that certainly adds to that is whether a procedure leads to adverse events or not. So looking at the FEMME adverse events, in the peri-procedural timeframe, there were actually no differences when you're looking at an intention to treat analysis. But looking at a per protocol analysis, so actually looking at those patients who had a UAE and complications they actually experienced versus those patients who ended up getting a myomectomy and complications they actually experienced. One of the areas that really struck me was that these women in the myomectomy group had a 10% chance of having a blood transfusion, which is not insignificant. And you can argue about what's the statistical best way of looking at adverse events in a trial. And most people would say, certainly statisticians would say, you want to look at the intention to treat analysis. But remember, this was a non-blinded study. Patients knew whether they were having a UAE or myomectomy. So I think that argument goes away a little bit. And I would say that it's still, even gynecologists that I've discussed this trial with would say that having a 10% need for transfusion is a significant difference from uterine artery embolization, of course. So again, on the flip side of this, we have a faster recovery time, but we're sort of condensing all of it into this short period of time. And therefore, I feel that the pain level is very accelerated and pretty severe, can be in the first 24 hours. So if you look, despite anti-inflammatory and PCA medications, greater than 90% of women report post-procedure pain. And then here's the really significant factor to highlight. 35% experience pain equal to or greater than labor. So this is not insignificant whatsoever. Some adjunctive techniques have been described and utilized heavily, particularly superior hypogastric nerve block and intra-arterial lidocaine. Some people have even gone to the extent of using an epidural at times, when either in planning or after the procedure if someone is experiencing severe pain. The point is that we have work to do in this space, and we know that in our shortened recovery times, we definitely have an accelerated pain level for a lot of women. So going back and looking at that initial list that we had of pros and cons, I would say our pros definitely remain in the pro category even after discussion of the data. In terms of the cons, I think it's all about setting expectations and really dissecting the data as best as we can. Regarding the fertility impact, what we've learned, and I'll kind of summarize for you, is that in older studies, there was a signal that myomectomy might be better than UAE. But I would argue that in our newer data, that they haven't been found to be significantly different, and that none of our studies really address this head on because of low power, low numbers, and then women having confounding reasons for having infertility given their age. I would also say that in looking at the data as a whole, and this was particularly highlighted in the FEMME trial, when you look at ovarian reserve factors, neither UAE or myomectomy seems to be affected. And so maybe we really overstated these differences, from our early data. Lastly, I would say when I talk to women about UAE regarding fertility, the conversation I have is the one that I would want to have if I were the one undergoing UAE. And I still talk to women with the discussion goes something like, I personally think there's probably some effect on fertility when we globally embolize the uterus, even though we know that the uterus tissue itself remains viable. I do think there's probably some impact on fertility or live birth rate. However, do I think it's significantly different from myomectomy? No. And I think if a woman, if their quality of life is so poor that they really need to seek an intervention before achieving fertility, I don't think this is unreasonable to proceed with. A lot of times women, when you have this frank discussion with them, what they're actually looking for is not fertility, but in fact, just uterine preservation. And sometimes the two are just misconstrued in conversation. Regarding residual and recurrent disease, as I said, anything that spares the uterus has this potential. And I would still leave that in the con category with regard to hysterectomy versus UAE. With regard to fibroid passage, I definitely pay attention to large submucosal and intracavitary fibroids and have a very frank discussion with patients about that potential and need for intervention to salvage the uterus or even potentially to lead to a hysterectomy if the uterus gets infected and is not controlled well. So I think that remains a reality. Now, there are some techniques that you can utilize in conjunction with GYN to make sure preemptively that you don't end up in that space. And then with regard to pain, as I mentioned, I think it's about setting expectations. You really have to counsel a woman who's undergoing this procedure that the recovery is great because we recover so quickly from this procedure. However, there is a pretty significant onset of pain after the procedure in that first 24 hours before you really start to see some light at the end of the tunnel.